I think we have at least 20, 15 odd people to join us. I hope they'll be joining soon. Thank you, Dr. Reena, for agreeing to spend some time with us again this year. Many of uh, you might know her. She is heading the Department of Continuing Medical Education at CMC Vellore. She has a background as a radiation oncologist in CMC Vellore and started the palliative care unit there. And she was heading the department till 2019. She has many publications in her name, and she was the chief editor of IGPC, which is the Indian Journal of Palliative Care. Uh, and she was actually involved in the curriculum making and how to plan these sessions. And we are so happy to have her here so that she can share some of her experiences. I think that's the most important part. I feel it is very, very important because people want to know how you did it and what was your experience when you teach all those. Like one question came yesterday. Why are you joining this program? So one participant was sharing. I don't remember who it was. Like I really want to know some how to teach certain topics in communication to medical students. So I'm sure this is very, very valuable. Thank you so much, ma'am, for being a part of this program again.
Thank you, Shri Priya and Shri Devi. I first heard about communication skills from Dr. Rajagopal when he was in Calicut, and that was after I had been an oncologist for nearly 10 years. So at that time, especially, it was not really a part of the curriculum at all. So let me begin by asking you a question. Many of you actually look quite young, huh? So I'm hoping for a better answer than I usually hear. How many of you were taught how to talk to the family of a dying patient during your MBBS days? Formally taught. Just put no or yes into the chat box so we just get a flavor. So far, all knows, even though you are a different generation from me. How many of you were taught and had to take exams on the life cycles of different intestinal parasites? I think we had a book called Chatterjee. So you can say again yes or no to that. And so there is a mismatch, isn't it? At least as far as I'm concerned, most of the time if a patient had an intestinal parasite, there were one or two drugs which I prescribed without reflecting very deeply on their life cycles or the philosophy of their life. Yet something which virtually every clinician needs to know about how to communicate with the family of a dying patient does not seem to have been a formal part of our curriculum. And I'm guessing that many of you are pioneers or outliers in taking the trouble to try and learn this. Please feel free to put in the chat box if I'm wrong in making this assumption. I know that in your earlier sessions, you would have had class on communication and ethics. So this session is more about how we can introduce it into a crowded curriculum rather than a class about communication skills or about ethics. So if you could just share my presentation, please.
चेक कर लेते हैं.
Can I have the next slide? So I'm hoping that by the end of this hour, I would have introduced to some ways even in which a small department can introduce ethics or curriculum into the MBBS curriculum. I hope you would have identified a few key components of communication in a teaching video and identified 4 cardinal principles of medical ethics in a couple of case scenarios. So the next slide, please. As was told to you in my introduction, that I started life as a radiation oncologist. And when I was a junior lecturer, which is what assistant professors were called in those days, I used to have to take two classes for the MBBS students. They would come to us in small groups. So for each class batch, I had to take two classes. And I loved radiotherapy as a subject. I loved maths and physics. So initially, I would take introduction to radiotherapy, and I taught them about radiotherapy and radiotherapy techniques a little bit and how fascinating the subject was. And I also taught them about common cancers treated with radiotherapy. I hadn't at this point actually had my palliative care training, but I began to think, the vast majority of these students are not going to become radiotherapists, but if they were clinicians, the vast majority, somewhere or the other, would see patients with cancer. And what can an MBBS student do for a patient with cancer? Not an MBBS student, an MBBS doctor. What can an MBBS doctor who's not an oncologist do for a patient with cancer? Just put in a couple of answers into the chat box if you don't mind. Makes it more interesting for everybody. I mean, I'm guessing none of you here are radiation oncologists, but you have done things for patients with cancer. So, what was that? Yes, one is discussion, supporting the family, pain palliation, LA anxiety, nausea, vomiting. Thank you. Now, as I said, at that point in 97, I had not had any palliative care training. So I did not think very much about anxiety or information needs, but I definitely thought about pain because I was seeing uncontrolled patient pain in my patients day in and day out. Okay, next slide, please. Okay, so then if you look at these two columns, which of them do you think is more relevant for the MBBS graduate? You can say first column or second column. Just put your answers into the chat box. Yeah, it's pretty obvious that this, and also this was something that at least an introduction I could take in that 1 hour that I had. So around 1997, simply by thinking about what is the patient, what can this guy do, and therefore what should I teach, I had fitted in the WHO pain ladder into the curriculum because that is something I had read upon earlier and I'd heard a couple of talks about. Next slide, please. And the first talk that I heard is from someone who you all probably have heard about. This was Dr. Robert Twycross from Oxford University. Dr. Twycross, in fact, is one of the founding authors of the WHO analgesic ladder. And not only that, before that, he was the person who did the initial studies on using morphine for cancer pain, who documented that morphine alone is effective. So anyway, Dr. Twycross was in India, and Dr. Twycross, incidentally, was also the person who trained Dr. Rajagopal. So Dr. Twycross was in India, and he'd been asked to give a guest lecture in our institution, and he told us about the WHO ladder. But he also said one thing which I still remember to this day, and I'm sharing with you. He said, "Don't worry too much if you don't have big resources in place. If it is something that is worth doing, start low, go slow, but do so." And this was very encouraging to me because I was a young person, I hadn't done big things, but this made me feel, yes, something I could do. And I'm sure each of you can as well. Next slide as well. Next slide, please. Then what happened next was that I trained in palliative care in the UK for a couple of years. And when I came back, I was lucky because in our institution, one of our consultants told the dean that from their posting, 3 afternoons could be given for palliative care training. Look at the generosity of that person. People are usually so territorial about their curricular time. And so, without fighting or without lobbying, I had 3 afternoons with the MBBS students who again would come in small groups. And again, you cannot teach all of palliative care in 3 into 2, 6 hours. But so I had to make a choice. Now, here, if you are choosing between the first column and the second column, which do you think is more relevant for the MBBS graduate? And even more importantly, which is more relevant for the patient that the MBBS graduate will teach? Yeah, so I think uh, we feel that the second is more important. And the next slide, please. Basically, one thing we need to remember that especially when we are training people who are new to the field or people who are not going to be specialists, rather than the fascinating frontiers in our specialty, we need to prioritize global competencies and skills that can be applied across clinical areas and beyond MBBS exams. Most of you would have done the revised basic course and heard about competencies and roles. And this is an important principle to remember because we all love our subjects, and when students come to us, we want to stuff them with as much as possible, which might evaporate very soon. Next slide, please. And today you're lucky because you can justify to your curriculum committee that the MBBS graduate not only has subject-based competencies, he also has role-based competencies. He has to be a communicator, he has to be a professional. We have AdCom modules. So today you can say what I'm doing is relevant. It's not some crazy idea. Next slide, please. So now to turn to how I tried in my experience to teach medical ethics in a 2 hour afternoon session. You know already that the 4 principles of medical ethics are autonomy, and a good example of that is informed consent, the right to self determination, beneficence, in simple words, doing good, non maleficence, not doing harm, and justice, here we are not talking about crime and punishment, but we are talking about an equitable or a fair distribution of limited resources. So these were the ethical principles that I wanted to get across to them. Next slide, please. Now, when we want them to discuss an ethical dilemma, how many of you would prefer to teach that through a complex, cutting edge topic like organ donation, stem cell research? And how many of you would prefer to teach it through regular clinical scenarios from your own specialty? Okay, so again, just put in first or second. Yeah, thank you for that. Because the little ethics that I had been taught was originally about some very complex cutting edge topics, and ethics is complicated itself. Then, if the scenario is also complicated, it becomes difficult for the student. So, I just chose some day to day clinical scenarios, real clinical scenarios with some details anonymized. I think it's important to remember, especially in today's world where we're doing so much online, that patient identity should not be compromised. Change the gender or change the profession. Next slide, please. Okay, next slide, please. So, when we're talking about informed consent, how do we give adequate information so that the patient can make a well thought out decision? Next slide, please. Okay, so this is a patient whom I had seen many, many years back when I was still in oncology. He was a man with metastatic cancer and supraclavicular nodes. He had come from a distant part of the country, very far away. And he took first line chemotherapy, and when the disease progressed, he took the best available second line chemotherapy. And then when the disease progressed again, then he was told that it is incurable and he was referred to us. Next slide, please. So when I spoke to him, he was crying. He said, I have two small children and my family depends on me. I took the best available treatment in order to be cured for their sake. I sold off my land and my house, and now there is nothing left for them, and I am going to die. Why did the doctors fool me? Fool me was the term he used. Now I know none of my colleagues are deliberately fooling patients. There is nobody has any financial stake in the treatment that is given, but there had been a gap. There had been a communication gap, and I was trying to break it down. How do we recommend treatment options in incurable disease? So then, when I started teaching students, next slide, please. Next slide, please. I said, the first thing is the patient needs to the level that he is able to absorb, have a fairly truthful idea about the prognosis and palliative intent. And sometimes I would use an analogy. I'd say, like, see, suppose you were going to buy a car and you had a choice between a Maruti 800 and a Mercedes. What would you want to take if you could manage the money? And many would choose the Mercedes. Let's say, but suppose that Mercedes had a permanent breakdown after 8 months, and if you found out that the person who sold you that Mercedes knew that this would happen and did not tell you, how would you feel? And I said, this is actually much more complex than buying a car. It is a irreversible life and death situation. And although we may try to protect people, when they make that decision, the decision makers need to have an idea. Now, at the same time, we should not be saying it, look, you're going to die in 3 months, so no point wasting your money. That's not the way to do it. But a sentence like this, when the cancer is in this stage, it is difficult to cure. With medicines, we may be able to reduce it for some months. Okay? We are still communicating a very difficult truth. And maybe at some point, this may be initially to the relative and later to the patient. It's better if it can be to both the patient and the relative at the same time. We are still communicating a very difficult truth, but maybe a little less harshly. Next slide, please. And then you give them options, because often what we do is we give the state of the art option. Okay? And you say, since it is difficult to cure, we should think about what suits you best. Like the most expensive drugs, which will also only temporarily reduce the size of the tumor, they may cost 25,000 a month. Some patients want something cheaper at 5,000 a month. And some patients may say, if the cancer is not going to be curable, they don't want chemotherapy at all. They only want symptomatic treatment or palliative radiotherapy. So we have put all three options down there. Now, what will we do after that? Any answers? What would we do after that? What would you want after that? Just think, if you have been given these options, what would you want next? Yes, we would go by the patient choice, but once we have communicated this, now again, so what I tell them, okay, we'll come to that after the next slide. Next slide, please. Then sometimes they'll say, okay, what is the advantage? No? Or even if they don't, it's our duty to tell them that The minuses are the costs, sometimes the side effects, and the time. Especially someone from far away, if he's going to spend 90% of his life sitting in a lodge outside my hospital, what have I done? The pluses may be improved survival in terms of months in more than half the patients if it's a very good chemotherapy, and symptomatic improvement in the initial months. So, those are the pluses and those are the minuses. But after we do this, I would suggest that maybe we should not immediately ask for their choice, isn't it? Instead, what should we do? And next slide, please. We need to give them time. Okay, these are very, very important decisions. And see, most of us, even if you're going to buy a mobile, I tell the students, you're going to buy a mobile phone or a laptop, will you buy it from the first shop that you go into on the first day? Especially if you've not researched it beforehand. So take time to discuss and decide. Sometimes in the anxiety, they say, doctor, we'll take whatever is the best. And the time doesn't have to be very long. Generally, you can call them back to the next outpatient because, on the whole, you don't want to waste a lot of time. But that is an important step, okay? So that we don't have information gaps when people make choices. Next slide, please. Okay, now we may have done all these things and tried our best to communicate the realistic prognosis. But how many of you have had patients who had unrealistic expectations even when we have explained the prognosis? Yes or no? Could you just put in your answers into the chat box? All the time, Dr. Harini said. Very often. Yes, it is very, very common because all of us like to hear what we want to hear. So, uh, next slide, please. So then I tell them again the true story of another patient who was a manual worker and who had pancreatic cancer with liver metastasis. It's almost 20 years back. And he's been told that the best chemotherapy would reduce the size of the tumor but not cure it completely. Okay, so nobody has really tried to cheat him. And he's insistent that he wants the treatment and would sell everything and take a big loan. Now, it was this man's wife's brother who came and told me this background. He said, if he does this, my sister will lose her house. She will be left with a loan she can never pay. Please convince him not to do this. We know that the disease is not curable. So, how do we address this situation? Yeah, the patient has not been told it is curable, but he's insisting on this treatment, which is clearly beyond his comfortable league. How do we address this? Any suggestions? What would you do? Put in a couple of suggestions. Excellent, Dr. Arun. Very rarely do I get that answer. He has said, discuss why he chooses so. Now, usually people will tell me things like, tell him it is useless, tell him he should think about his family, you know, convince him. Okay. So, next slide, please. Okay. So again, Dr. Parul has said, sit with the patient and caregiver. So basically, acknowledge where they are coming from first, okay? Because people had already tried telling this man, look, no, this is useless and all, and then he got angry. He said, it is my life, it is my money. Why are you preventing me? So I said, okay, I understand you want this expensive treatment, but can you just tell me that if you sold your house and if you took this treatment, what are you hoping for? So then he told me, he said, next slide, please. I know it is not curable, but at least with this, if I take this expensive treatment, if I get 15, 20 years more, then by then my children would have grown up, and then it doesn't matter what happens to me. So you see, he was not taking this in order to harm because he didn't care for his family. He was taking it because he wanted to be there for them. So then now we know where the communication gap is, and we can address that. And it was with this patient that I realized that maybe a picture is better than words. So, on the back of the prescription, I drew a diagram which I will share with you. Next slide, please. So the red line is that, see, the cancer is there and it is growing like this. If we don't do any treatment, it is continuing to grow along the red line. We don't have any treatment that will cure it. We don't have any treatment which will reduce it for many, many years. If we give chemotherapy, in less than half the people, not even in everybody, it may reduce for a few months, but after that, again, it will grow. Okay, so in a way, as I was drawing the diagram, I was talking to him, and it took less than a minute. And he said, "Oh, if that is all it is, then please let me go home. I have many things to settle for my family." And so we gave him some painkillers and he went. So that's when I realized very often a picture or a written thing helps a lot in these communications. And I used to share this with medical students. Next slide, please. So, is this a clinical ethics scenario? How are the principles of medical ethics coming in into this case? Can you identify a few principles? Yes. So one, there was about autonomy and informed consent. Yes. Dr. Melita has talked about beneficence. Dr. Prashant has said justice. Could you just unmute and tell me, Dr. Prashant, why did you say justice?
Ma'am, is it how it is right for that particular patient? We are giving the options. It is his life, he has to decide. That is one part.
Yes.
Hello,
Yes,
can you
yes.
hear me, ma'am?
We lost you for a minute, yeah. We've lost you again, I think. Yes, Dr. Prashant.
Again, there is a financial issue is also involved in that one. And
Yeah.
at the same time, the resources also needs to be properly distributed, particular to that, pertain to that particular patient. So
Yes,
all those factors need to be assessed and decided.
exactly. Thank you for that. Can we just have the information on the slides? Okay. So, was this an equitable use of resources for a poor family with young children for the next 20 years? Was informed consent truly informed? And did the benefits outweigh the burdens? So, we tell students that every day when you see patients, you're actually practicing clinical ethics. It's not just during your ATCOM module. Next slide, please. Can we have the next slide? And then we go a little bit to the jargon. So, this is an ethicist writing that whenever we try to help others, we inevitably risk harming them. Healthcare workers who are committed to helping others must therefore consider the principles of beneficence and maleficence together and aim at producing net benefit over harm. And that's what we do all the time, isn't it? We don't give chemotherapy to someone with a non serious illness. We don't give blood transfusions just to build up the hemoglobin from 15 to 16. So that is the crux of clinical ethics in a way. Next slide, please. But we also need to remember that when we recognize patient autonomy, it means that what one patient may see as a benefit, another may see as a harm. I think you're all in agreement with that, isn't it? Huh? Just because I would want something, I cannot expect every patient of mine to want that. Okay, so then I tell them another case history. Next slide, please. Can we have the next slide? Okay, so this was a very senior government officer about 20 years ago who had hormone refractory prostate cancer with bone marrow infiltration and visceral metastasis. And in those days, there were virtually no worthwhile systemic options. But he and his family were very keen to try. And even though we repeatedly explained the benefits and the side effects, they continued to be very keen. And it is not that this man was very rich, okay? He was in a general ward. He had all his treatment in a general ward. And then his son told us, next slide please, that this man's first grandchild was due in December and they wanted to try and prolong life by at least a few months. So we gave the chemotherapy and he had a lot of side effects. He spent almost a month in hospital, but he lived to see that grandchild. So how is this scenario different from the previous scenario? Can I have some answers in the chat box? How is this different from my first patient with supraclavicular nodes? Who Yes. Okay, so Dr. Punitavati and some of you have said, next slide please. Next slide. That he had a realistic expectation. Okay. So there was patient autonomy. He was aware of the costs and benefits. And his expectations, although I couldn't guarantee that the expectations would be met, there was a chance they could be. Okay. So there wasn't that expectation reality mismatch, which means that informed consent was informed. The next slide, please. And that is why when we talk about shared decision making, we put the cards on the table, we see what is important to them, and we try to come to an individualized plan. Next slide, please. So that was a little bit about, so all this was taught in a 1 hour class in the afternoon. It just sensitized them to these principles. Then another afternoon was on teaching communication skills in limited time. How many of you here are already teaching communication skills in some way or the other? Can you say yes or no into the chat box? Whichever way it is. Either a yes or a no. Great. Huh? So, would one of you who's already teaching just tell me a little bit about it? Which year do you teach and what techniques do you use and what numbers at any given time? Just unmute and tell us.
Hello.
Yes. Yes, Dr. Anupama?
Yes, ma'am. Usually we prefer role models and
Right.
we teach them mostly through role model because I feel that they are more involved when we do what went wrong with the first scenario and what was right in the second scenario, especially for communication skills.
Yes.
So we have often found that they are very interested and they know they easily catch up with those things.
Yes. Yes, thank you for that. I mean, communication skills is not something we can teach by lectures. And like you said, when they see a role play, they wake up and they get interested. Then, Dr. Prashant, would you like to tell us a little bit about what you do?
Ma'am, posted in our ICU are regular postings. They come either from anesthesia or inside, where we actually we will be counseling to the actual patient relatives. They will be witnessing. After that, we'll do the debriefing. What needs to be done, what we have done, and how it is to be done. That is the way of communication. How we need to talk to the relatives when it comes to the ICU.
Fantastic. This, so when we have people who are, interns or postgraduates, so with interns and postgraduates, not, I didn't have interns with me, but we used to have all the radiation oncology postgraduates rotating through us. This was the method we followed when they actually see it in real life. And sometimes, in order to keep them focused, I would even ask them, I want you to note down, what they ask and what I say, and then we will discuss it later. Now, again, now suppose you are having all these postgraduates sitting in when you're counseling this family in the ICU. How would you arrange the seating? Dr. Prashant, would you like to tell us?
Ma'am, we have a chair and a table where me or other consultants will be sitting on one side, the other the relatives.
Yes.
And to the side, I mean, both the left and right hand side, we have a couple of benches and the chairs where the interns will be sitting, which will be, I mean, on the top, there will be a camera. That is how our present setup is.
Right, you have a camera as well. Oh, great. So that allows a
Yes,
lot of...
audio, video.
Yeah.
Yes, recording.
Now, there are two other things I would like to add. See, in general, it would be good if your observers are not in the line of sight for the patient and relative. You take the permission from the patient and relative for them to be there, but if they're facing an interview board of 6 people, it can be a little unnerving for them. Whereas if the students are sitting behind them, they know that they're there, but it does not impede communication as much. And then, of course, in a serious conversation, if we are audio videotaping, we probably should get their consent because it can be a very emotionally fraught thing for them. But in general, if people can see real life explanations and have a good debriefing, that is a very, very powerful tool of learning. I still remember hearing Dr. Rajgopal talking to an amputee patient, and it taught me so much. Right, next slide, please. Okay, so like you said, we could use demonstration role plays, bad and good. Now, one caution that I would like to say is that sometimes the bad role play becomes very exciting, very funny, isn't it? Because we do all kinds of exaggerated things and the students laugh, and the danger is that they may remember the bad role play better than the good role play. So I think keep your bad role play somewhat realistic and not very, very bad, and emphasize the good role play. Okay. Then another technique is videos. Now, with how many of, yes, a checklist is good for both of them. How many of you feel that when we use videos, we are better off with a Western video or an Indian video? Could you just put your responses in the chat box and give your reason for whichever response you choose? Yes, so far most of you have responded Indian. So why do you say that? Could you put those answers there as well? Okay, we have familiar faces. Yeah, so yes, so Dr. Yadav has given the answer to the question I was going to ask you, that why are most of you choosing Indian videos even though there may be some very professionally produced Western videos. Okay, but I think I would agree with the majority of you that when a student sees a Western video, he thinks, that is okay in England where they have plenty of time and where their patients are well educated. Okay? But when they see it in our context, like you said, the situations may be different. And we are trying to show that this is just as important in our country. Tell me one thing. Okay, let's take a little vote on this. When do you think doctor-patient communication is more important? With a well-off literate patient or with a not well-off and somewhat simple patient? When is it more important? Choose one, choose one. Should be with all, I agree. But if you have to invest extra time, with which group is it more important? Okay, so we have a majority saying literate, but a few people saying illiterate. So those of you who said literate, okay, who can I ask? Dr. Govardhani, why did you choose the literate patient?
Well educated.
Sorry?
Dr. Govardhani, you are muted. If you could unmute from your end, please.
No. No.
I think there is some issue with the device.
Okay, okay. So someone said that the literate patient may have more doubts. See, I think by default, what we tend to do is that we give more information to the well-educated, well-off literate person, partly because it could either be because we are trying to be defensive or because we think they will understand more. And Dr. Prachand, that's very true. Literate doesn't mean that they understand all. Sometimes I have had huge communication challenges with highly educated software professionals or highly educated doctors for that matter. But I think the main reason why I feel we need to put in more time with the simple, not necessarily illiterate, but with a simple person is because if they don't understand, they may make wrong choices. They are at a greater risk of making a wrong choice. You know, either taking inappropriate treatment or not taking appropriate treatment. Yeah, so all of these scenarios are better done if we have an Indian video. Then over the years, we also did a few faculty development workshops because you can only teach so many people, but if you train people, they can continue teaching so many more people, and that's what Palim India is doing with all of you. I can't imagine the long-term goal of. By the way, just for my knowledge, since I'm meeting you for the first time, into the chat box, just put in which cities you all are teaching in. We also made a little booklet. Next slide, please. Okay, so really from north to south, center, east, west, all over the country. We also made a little booklet with some common communication scenarios. Next slide, please. Yes, so from Dehradun to Kollam, Vishakhapatnam to Ernakulam, Bhopal. Now, a lot of the time, when we teach communication, the first thing we like to teach is breaking bad news. Yes? Because breaking bad news has clear steps and there are a lot of resources on that. But I think it would be good if we could begin with something a little broader than that. Okay? And I will try, and some of you are probably already doing that. Next slide, please. Okay, so I would like you to watch this video and note down two important principles in sharing information, one ethical issue. And before we start, if anyone here, does anyone here know what ICE is? Would you like to unmute and say? Right, so let's go on to the video then. This was a video that we made. Okay, what did ICE stand for? ICE? Anyone wants to put the answer in? Yes, listening, very, very critical. So you see, what did the patient come to the hospital for? He came only for pain. But there's a whole iceberg underneath that pain. Okay? Yes, ideas, concerns, expectations. Now, what is Anand's idea about his disease? Does he know he has cancer? He has cancer? Yes, he knows he has cancer. Yes, Dr. Harini. He has an unrealistic expectations. He wanted a non-surgical cure. And a concern was that he was scared of losing his livelihood. I think I would say he knows he has cancer. It's not that he's refusing to accept it, but he doesn't want surgery for the cancer. And then there was that sentence about after the biopsy, the pain got worse. What is at the back of his mind there? Yeah, there is a fear that any cutting into the tumor will make it worse. Yes? So what do you think we should do for Anand? He's afraid that the surgery would increase the tumor. Is this a curable cancer or a non-curable cancer? T1, N0, M0. It is very curable. And untreated, within some months, it will become really nasty. Now, I think it's worth us remembering this because sometimes to our palliative care clinics do come patients who have very good options. And we just need to have our antennae open for that as well. So how do we, is there a communication gap here? How do we bridge the gap? What could we do? Remember when we had the other man with the pancreatic cancer who wanted chemotherapy? We said start by acknowledging where he's coming from. Then explore, and then give information. Yes, and yes, Dr. Mohammed, the surgeon behaved in a appalling way. But do you think these things happen? Is it very rare or not so rare? What are your answers to that? Do you think doctors behave well? Unfortunately, it's not rare, isn't it? And in a way, that is why it's so important that people like you all are teaching communication and ethics in all corners of the country. Right, can we return to our video? So that's a video which is not really breaking bad news, but it's about gathering and giving information. Can you just put in, one thing that you found worthwhile or useful in that video? Just put it into the chat box. Nothing at all? No, it's really interesting because um, when I wrote the script for this video, I was thinking about the various points I need to cover, ideas, concerns, expectations, listening, chunk, check, analogy, signpost. I wasn't consciously thinking about the non-verbals. I just, spoke to the person who was playing the patient. But so many of you have talked about the non-verbals. But that's a fact. Actually, in communication, more than half is the non-verbal. And I think that comes from the heart, how we genuinely feel about the patient. But the few things we were trying to illustrate here is that if we listen, then we can understand the individual. And behind a very run of the mill, oh, I've come for pain, there may be a whole story. And sometimes that communication gap can really kill lives, isn't it? I mean, this man would have died if we had just let him go like that. And especially with modern medicine and modern technology, I mean, naturally, students are enamored of the latest scan and the latest paper. But that a very ordinary thing like this can also save life is a message worth conveying. And the second thing also about that, when we give information, like I tell them, I take this lecture, you won't remember 80% of it tomorrow. And when your patient is emotionally stressed, you can't expect him to remember big lectures. You have to break it down into points and give them time. Right. So we have a little time. Okay, what was one ethical issue in this video? Other than communication, what was an ethical issue that came up here? It was in a buried comment which the patient made. Yes, money making. Yes, Dr. Harini. Where did he say that?
He said big hospitals make a lot of money and nothing,
Yeah,
give
he
no
said
cure.
that's what. Patient died, only the hospital got bigger. Okay, yeah, and there is some truth in that, which is unfortunate. And then there is also the fact that even when we are genuinely treating, the profession has lost the trust of patients, isn't it? Because of some bad examples. And that is another reason why communication is important. Now, this conversation took maybe about 10 minutes. Is that too long for this scenario? It's not. The conversation took 10 minutes and the commentary took a few minutes more. It is a life and death matter, isn't it? And we are also trying to illustrate that we can actually have critical conversations without needing to take 45 minutes over it. If we spend enough time listening and then address the communication gap correctly. And also another take-home message that I give them is that even if you feel it is too long, remember when you build a foundation of a house, that is a point where you will not cut corners. Okay? You won't say, okay, let me build my foundation in a week and then everything else will grow fast. And those first couple of encounters are very critical. Right. So that's all I had to say. Is there anything you would like to ask or comment? How many of you found it helpful to have the subtitles to the video? Not the subtitles, the signposts, whatever, the captions. Just put yes or no. Yeah. Earlier, when I was involved in making communication videos, I didn't do that consistently, but I think it helps because, especially when people who are new to communication see it for the first time, you can't take everything on board, and the conversation is continuing to move on. So I think captions are important. So one thing I was wondering is, how many of you would find this video useful in your own teaching? Those who would, can you put in a yes? Okay, so if that's the case, perhaps we could do two things. One is, we can share the link with you. And the second is, I might request you to just share a feedback form with your students. A little bit about what they learned and a little bit about their suggestions. This was a very amateur attempt at our making a video. And we will all learn something from that. Would that be okay? Would that be okay, Dr. Shripriya?
Ma'am, I am not a doctor basically, but yes, of course, if you are providing the feedback links, you will share it with the participants and get it done.
No, what we'll do is we'll provide the link to the video and
Okay.
we'll get the
That
feedback.
we already provide, ma'am. I already have the link with me, so I can put it across in the LMS so that the participants can access.
Just give me a day or two to design a feedback form for the students.
Sure.
So that when we use the video, not just feedback, but also kind of learning points. Both can be used together and that will be worthwhile.
Okay. Sure, ma'am.
I'll do that. Yeah. Right. So I think we are close to finishing. So thank you, Shripriya, and thank you all for participating so actively, and all the very best with trying to teach communication and ethics in the curriculum.
Thank you, Reena ma'am. Thank you so much. We do know you are in between ABC schedule even now. So again, still you found out time to join us, and we do understand that it is really your passion which makes you agree to all our sessions, because we generally trouble you requesting for sessions at the last moment and you agree without any hesitation. Thank you so much for that. And I believe that everything what ma'am told today, including the video, would have been an experience which enriches the knowledge of all the faculties out here. So actually, we were expecting Dr. Sridevi Warrior to share a brief actually about tomorrow's topic and what all needs to be done. But unfortunately, she had to leave this meeting and join another important meeting. So she has left a message. She had conveyed her special thanks to you, Dr. Reena, as well. And regarding for the instruction for the participants, we might be sharing her voice or video recording. So very soon, once the other meeting is over, we'll be recording it and sharing it in the group so that everyone is well versed. The learning materials have already been shared in the group as drive links, which I believe everyone has got access to. In case anyone is facing difficulty to access the same, please do let us know. And regarding the basic idea is this, once we have provided the modules of communication, which is tomorrow, you just have to brainstorm. Each individual group has to brainstorm how you will be teaching your students the given topic and then present it in the large groups. That is how it goes. I'm really sorry that I'm keeping you waiting for the further information till the time Dr. Sridevi joins in, because I am not a medical person and not in a capacity to provide complete information. That is why. So thank you for joining us, and we are letting you go 15 minutes prior the schedule so that you can enjoy your hot cup of coffee or tea and then go back to your works. So thank you everyone for joining.
I have these subgroups, what we have formed, no, what activities are we planning for that?
That is what Dr. Sridevi is that person to give you the complete guidelines, but unfortunately she is not available live in this meeting. So what we will do is we will get a recording. We will get a detailed recording how things have to be done, how things have to be planned, and that will be shared in the group.
Oh, okay.
Maybe
Thank you.
by 5 p.m. or 5:30 p.m.
Okay.
Hi, Harini. By what time we will know?
Ma'am, please wait till 5 p.m. I suppose her meeting will, as soon as her meeting ends, we will
Put it in the
definitely.
group, right? Okay.
And will this video link be shared in the YouTube?
Sure, sure. What video Reena ma'am right now showed to us, it will be shared as separate material in IFO. We have not included in the recording because it will cause YouTube infringement. Even though Reena ma'am has kindly consented to share it with us, YouTube will identify it only as a copyright infringement. That is why we are stopping the recording when the video is played. Of course, we'll be sharing the video as separate.
So the feedback form and the video link we can share together.
Okay.
Thank you, Sripriya. I mean, Pallium India has done so much for the country, you know, and over so many years. It's I can't even begin to say.
Ma'am, Pallium India as alone such an organization is nothing, ma'am. It is because of your association of eminent people like you that we are able to do what we are doing today.
We all learned from you all. So, yeah.
Dr. Reena ma'am, I have a question for you.
Yes.
I'm Dr. Uma here. It's really become a little bit difficult to sensitize faculty how to teach. Like, because now it's come in the UG curriculum.
Yes.
Those of us who are doing palliative care, when we are taking classes, we are able to say something. But it is there in the, like in CBME, we are seeing, right from first year it's there. But
Yes.
it really sensitize faculty how to go about it. I'm finding it little, I won't say it's difficult, but a change of thing is not happening as we expect. How to go about it, ma'am?
Yes, the fact is, you can take a horse to the water, but you can't make it drink. But what I would say is don't get discouraged.
Yeah.
If you share it with 100 students, even if 5 of them take it on,
yeah, that's
it will
true.
multiply. So focus on, don't worry about the ones who are resistant.
Yes.
Focus on the ones who are receptive, and then over a time, the norm changes.
Yeah,
Like,
thank you.
10 years back, we didn't even have communication in the medical curriculum at all. Now it is compulsory.
Yes, ma'am.
While we'll wonder, oh God, how come we never had it? Okay. So focus on the positive, focus on the receptive, and leave the rest. Is what I would say.
Thank you. Thank you.
And sometimes videos are often more effective than lectures. That's another point. Yeah.
Yes, ma'am. We do some videos in the simulation lab, 2 or 3, and with that we try to teach all these role plays. It is really more effective than just a simple teaching.
Yeah.
Then they're all able to understand better. That's true. Yes. Thank you.
Thank you. Thank you.
Thank you everyone for joining in, and please do wait for the detailed instruction video or audio from Dr. Sridevi in the group. See you tomorrow again with, tomorrow actually it is going to be, anyways, whatever the topic is, tomorrow is going to be a very happening day, busy day, because we will be starting with the breakout rooms from tomorrow. The participants will be, I can just give you the outline picture of how the activity is going to be. We'll be directly sending all the participants to breakout rooms as soon as you join to your respective breakout rooms. The room numbers will be same as your group numbers, 1, 2, 3, 4, 5, and you will be sent to the breakout rooms directly once you join the meeting. Whatever activity you are doing, it will be inside the breakout room with eminent faculties joining in to monitor. Once the breakout room timing is 30 minutes, within which you have to discuss the strategy, how you are going to present the topic, teach the topic to the particular students. And once you come back after 30 minutes to the main room, one representative from each group will be presenting the topic to the main group. That is how the entire system goes. Just updating, because you can, I'm briefing this now because you may choose one person from your respective groups who will be presenting the topic to the bigger audience. That can shift also, like one day if one doctor is presenting, the next day another can present, or even one or more participants can present tomorrow as well. So this is the general process of the breakout rooms. So see you tomorrow. Please do make sure that you are logging in time so that we are able to allot you the rooms without delay. And stay tuned for the message from Dr. Sridevi in the group. Thank you everyone for joining in. See you tomorrow. Till then, everyone take care. Bye-bye.
Thank you. Bye.